Welcome to our section on renal papillary necrosis. Let's begin. Here is a list of topics we will be discussing for this section. Let's begin with the definition. Renal papillary necrosis is defined as coagulative necrosis of the renal medullary pyramids and papillae. This is how renal papillary necrosis looks like under histological exam. There is presence of granulation tissue identified by the presence of blood vessels and immature fibroblasts. Also, you can appreciate the fibrin exudate right here. Renal papillary necrosis can be caused by factors that lead to necrosis of the renal papillae, some of which are acute pyelonephritis, urinary tract obstructions, analgesics such as NSAIDs and acetaminophen, sickle cell disease, diabetes mellitus, chronic alcoholism, and systemic vasculitis. Now let's discuss the pathophysiology of renal papillary necrosis. The various etiologies mentioned in the previous slide lead to hypoperfusion of the renal medullary pyramids and renal papillae. Renal papillae are located in the apex of renal pyramids and are very susceptible to ischemia due to the small caliber of supplying vessels. This results in necrosis, and eventually the sloughing off of the papillary ensues. The sloughed papillae pass forward along the urinary tract and can obstruct the ureters. This can result in renal failure due to increased backward pressure on the kidney. Finally, during the process of healing, renal scarring occurs, resulting in permanent damage. The disease course of renal papillary necrosis may be acute or chronic, and patients are usually asymptomatic in chronic cases. However, they can also present with fever, hematuria, and flank pain. Other features of acute kidney disease, such as oliguria, anuria, and uremic encephalopathy, can also be present in patients with papillary necrosis. Renal papillary necrosis is a diagnosis of exclusion. Increased BUN and creatinine, hematuria without red blood cell casts, and proteinuria are common findings. CT scan may reveal renal papillary calcifications and filling defects. Irregular papillae and filling defects in renal pelvis on intravenous urography are also suggestive of renal papillary necrosis. Treatment of renal papillary necrosis is a discontinuation of analgesics and treating the underlying cause. Supportive management, such as adequate hydration, should be maintained to increase blood volume and overcome renal hypoperfusion. What area is most likely to experience necrosis in a patient with sickle cell disease and chronic NSAID use? Both sickle cell disease and NSAID use are potential etiologies of renal papillary necrosis. The renal papillae are here. This diagram illustrates well why the renal papillae are especially vulnerable to hypoperfusion, as most of the blood vessels run along here. As you can see on this image, renal papillae are supplied by the most distant arterial branches that usually have a smaller caliber. Thus, renal hypoperfusion, whether it is due to sickle-shaped red blood cells obstructing capillaries or the impaired prostaglandin-mediated vasodilation due to NSAIDs, would affect this area disproportionately. A 21-year-old African-American man comes to the emergency department due to progressively worsening diffuse bone pain that started 3 days ago. He also reports no urine output for the last 2 days. His vital signs include a temperature of 37 degrees Celsius, a blood pressure of 125/70, a heart rate of 95, and respiratory rate of 16. The physical exam reveals diffuse bone tenderness and 2+ bilateral pitting edema on the legs. Complete blood count indicates the presence of anemia, while peripheral blood smear shows sickle-shaped red blood cells. His BUN is 30, and serum creatinine is 5. Urinalysis is significant for 2+ red blood cells and 3+ proteinuria. Which of the following is the next best step in the management of this patient? A. IV fluids. B. Hydroxyurea. C. Naproxen. D. Ibuprofen. This African-American patient presents with progressively worsening diffuse bone pain, no urine output for the last 2 days, and 2+ bilateral pitting edema on the legs. Complete blood count indicates the presence of anemia, while peripheral blood smear shows sickle-shaped red blood cells. All these findings are consistent with sickle cell crisis due to sickle cell disease. His BUN is 30 and creatinine is 5. Urinalysis is significant for 2+ red blood cells and 3+ proteinuria. These laboratory findings of intrinsic acute kidney injury in the setting of sickle cell crisis are consistent with the renal papillary necrosis. The next best step in the management of renal papillary necrosis is to treat the underlying cause and hydrate the patient. Intravenous fluids will reverse the sickling of the red blood cells. Therefore, the correct answer is option A. Here's a slide reminding us of the treatment of renal papillary necrosis. Let's discuss why other options are incorrect. Option B, hydroxyurea, is incorrect because although it's used for chronic management of sickle cell disease, it will not treat the acute sickle cell crisis or renal papillary necrosis. Options C and D, naproxen and ibuprofen, are incorrect because although this patient needs analgesics, we should avoid NSAIDs in the setting of renal papillary necrosis because these medications can worsen the renal papillary necrosis. And that concludes our lecture on renal papillary necrosis.